Hi, this is your producer, Kadisha. Before we start, we'd like to note that we discuss sensitive subjects that might be distressing for some listeners and readers throughout this episode. Please be aware that the content includes discussions about medical discrimination, racial health disparities, testimonial injustice, and ableism. Your well being is our priority. If these topics are triggering for you, we encourage you to consider seeking support during the time you engage with the content or choose to skip this content overall. Take care of your emotional well being and prioritize what feels right for you. Now, on to our episode.
Doctors with disabilities exist in small but measurable numbers. How did they navigate their journey? What were the challenges? What are the benefits to patients and to their peers? What can we learn from their experiences? My name is Lisa Meeks, and I'm thrilled to bring you the Docs with Disabilities podcast. Join me as I interview docs, nurses, psychologists, OTs, PTs, pharmacists, dentists, and the list goes on. I'll also be interviewing the researchers and policymakers that ensure medicine remains an equal opportunity profession.
Welcome back to another episode of the Docs with Disabilities podcast. Today, in this second half of our two-part series with Dr. Diana Cejas, Dr. Meeks and Dr. Cejas continue their conversation by diving into discussions on the gaps between praxis and practice, benevolent ableism, and ways that access is often sacrificed at the expense of optics.
What strikes me is as we work to kind of create resources in graduate medical education is still this big gap between what a medical school knows to do and how residency is truly this kind of Wild West. It really, the best that I can tell from our qualitative and quantitative research is that it depends on who your PD is. And depending on one person is never a good scenario. But all of this ancillary stuff is happening too, like your peers, your cohort is so important in that mix, and having their support is so important. I listened to you talk about how you had to organize and think of everything and have everything done. So no stone was left unturned before you could go get a PET scan. And that just is shocking to me, just shocking that that is the message that was sent out. We're not talking about decades ago. I mean, you're still a newer assistant professor. That idea that this type of thing is historical. This thing happened, not for you particularly, but this happens is proximal as last week. My emails constantly blowing up with learners that are experiencing barriers that are unnecessary or discriminatory behavior. Something else you brought up is this idea of benevolent ableism. And I wonder, for the people in our audience who don't know what that is, could you describe that a little bit more?
I feel like and certainly this is not a definition that you're going to see. There's probably people who have more coherent kind of definitions for benevolent ableism. But when I think about it, I'm thinking about it as being like a kind of way that disabled people can be infantilized. Like, oh, you poor thing. Oh, or even not just the infantilization part, but even the aspect of, we're thinking about like things like inspiration porn. There was a video that actually came out this week of someone that was, I can't remember where it was, but they were a wheelchair user or their child was a wheelchair user, and they were like carrying them up the steps. And there was a tweet from, I don't know, CBS News or something like that, talking about, oh, isn't this amazing? How inspirational, how beautiful. No, that's a systems failure. Like, this person shouldn't have to do that. They should be able to get up the stairs like anybody else. But, when you see people that were commenting on it, they're like, this is amazing. How inspirational. This is beautiful. What a wonderful thing. And it's like, I guess that sounds like it's positive, but it's really not. It's really based on, again, this like ableist principle. I've had people who be like, oh man, it's like just so inspirational right after I got out of the stroke. I had the stroke. And I was going to the grocery store because I had to go to the grocery store because I have to eat. And they're like, it's so amazing that you can like get up and do that for yourself. Well, who else is going to do it? Like, I have to be able to do it. I'm not inspirational because I'm existing as a disabled person in this world. I'm just here. When I think about benevolent ableism, I think about people who think that they're coming from a really good place, but actually they're coming from the stereotype that disabled people, are worth less or cannot do or should not be or cannot go. Even when I talk about the fact that I'm, disabled and a physician, sometimes I will still get those kinds of things like, wow, it's so amazing, that someone like that could do this. And I'm like, well, yes, no, it's just coming from that place that like a disabled person is not really a person and can't do the things that other people can do or shouldn't do the things that other people can do. So it's like we're kind of romanticized but infantilized, and it's very, very, also very, very strange.
I think the best example I have is when a medical school accepts a disabled learner, especially if the disability is apparent, and then hypes up their acceptance of that learner. And when it comes time to enter the clinical environment, starts waiving things. Well, you don't have to do this. It's okay. You don't have to do that. It's okay. You don't have to do this. So you're not creating access. You're creating optics. And what you're saying is, I want you because you're disabled and you're checking a box for me right now. But I don't think that you can do these. I don't truly believe you can do these things. So we're just going to have you get through medical school with the least amount of engagement possible. And we're going to say we're doing it for you. We don't want to overextend you. We don't want to burden you. But I push back on medical schools when they start doing this. And I say, is this really about the learner, or do you not want to do the work that it takes to evaluate your clinical environment and your clerkship and create meaningful access for this learner, which might require you to challenge your assumptions about what they can and cannot do? It might cause you to adjust somewhat how you approach a particular clerkship or a particular procedure. Are you willing to do that? But then it is this, I think, internal, but I'm just trying to be nice, but I'm just trying to be helpful, but I'm just trying to, I'm willing to waive this. That's the hardest thing, because people genuinely think they're coming from a good place. They genuinely think they're doing something for the learner. And when you challenge them, it's so hard. It's such a delicate dance because they truly believe that's where they're coming from. They don't see the ableism. And so you have to almost break it down, I think. Does that make sense?
No, it definitely does. And I think just even thinking about how we're practicing in pediatrics, benevolent ableism is all over the place within pediatrics for sure. And there'll be times when I'm giving talks about it and I have to kind of explain like a common thing that I will get is, oh, if you have a patient who has epilepsy, well, don't you want to cure their epilepsy? Isn't that what you're trying to do? And isn't it a good thing to not want epilepsy or patients with epilepsy to exist? And I'm like, hold on a second. Let's think about how you just said that. Also, I think that there's definitely a way that you can treat someone and treat their medical condition or provide support and treat them as if they are a human and then also recognize that the cure of X, Y, and Z is not always the goal. Sometimes it is, but sometimes it's about supporting that person because we know we can't necessarily provide a cure, and we need to at least make sure that the person can live the life that they want to live, that they see as good and good quality for themselves. That's a whole nother thing. But it's like as you were talking, I was thinking about that, and then kind of thinking of the flip side, where I will have learners, and even have some of my own experiences, where the second you can't do something that you have told them you can't do because of your disability, or you're going to have trouble with because of your disability, or you need accommodations for because of your disability, you are almost like demonized. Like, why can't you do this? Well, you should have said that you couldn't do this. Or, well, you're not performing up to the level of another resident. You should be able to do X, Y, and Z. It's like when I told you up front, I had this situation, and now you're trying to penalize me for having the situation that I told you about, which I told you that I needed accommodations for. So it's kind of like, you know, you might get into that situation where someone is trying to be like, oh, well, you don't need to do this, and you don't need to have these supports, and we're kind of being so gentle about things. But the second you slip up, or not even slip up, the second that you show that you need the accommodations that you truly say that you need, suddenly now you're a burden. Suddenly now that you're being tracked out, suddenly now you're being penalized. And thinking about the fact that, how many disabled residents out there don't want to request accommodations because they don't want to go through these things. They just want to tough it out, as it were. How many times do we already see, and don't throw the fact that if you have residents who are Black, if you have residents who are other people of color, other ethnicities, what have you, we're already at risk of being, tracked out at a higher rate, or dismissed from residency at a higher rate, or put on probation, what have you, at a higher rate, again, because of racism. And now we've got the ableism on top of everything. It's a a very vulnerable position for someone to be in. And I can imagine like the kind of feeling that you get, like it kind of feels like whiplash, where you've got people who are like, oh, we're trying to be kind of kindly ableist to you. And the people who are more malignantly, although I don't think that there's really a difference, ableist to you. And now you're kind of caught in the middle. And who knows how things are going to turn out.
I think another really good example of this for all of the admissions folks listening is when you're sitting around that admissions table and someone says, I just don't think it would be fair to accept them. I just don't think it would be fair to set them up for failure down the road. Residency isn't going to allow this, so we shouldn't really be giving them extra time, or we shouldn't let them address this procedure in another way, which is uninformed at best, right? You don't actually know what's going to happen downstream. I think most of us are shocked by some of the things that happen, good and bad, at this point, right? But also, it is not about them. It's about you not wanting to do the difficult work of auditing your environment.
Right. I mean, I've sit in some of these conversations when we're talking about bringing in new residents or medical students. And I remember one in particular, a couple of cycles back, where we were discussing this applicant. They were an amazing applicant, and they disclosed their disability as part of, I think, their personal statement or something like that. And having this conversation with people where they were like, yeah, they disclosed their disability, but they did really well on the steps. And I'm like, okay. They're like, but sometimes they use that kind of thing as a crutch. And I'm like, hold on a second. Here's another opportunity for me to like just insert a couple of things here. And then we had to have this whole conversation, and they're like, yeah, but usually when people talk about their disability, they want you to know it's because they can't do X. I'm like, listen, hold on. Like, let's kind of reframe this conversation. You just said this person is an excellent applicant. I just said this person is an excellent applicant. They happen to disclose their disability and said why in their statement. Okay, they felt comfortable enough to disclose their disability and tell us why. Fantastic, wonderful. They're an excellent applicant. Let's figure out, if we want to extend the offer or what we were trying to do here. And I'm sure that this person said that with like what they thought were good intentions, but it's like you have to kind of take a moment, think about how you said that. Think about what that means, like what you were expecting from a disabled trainee and what you expect, that not from just that disabled trainee, but disabled trainees in general. Yeah, I really would love to never be surprised by these kinds of things, but every time it happens, it's like a bucket of cold water. It's like, hold on, can we just take a minute and think about what we're really saying here?
In this segment, Dr. Ciaz shares what disruption means to her, ways that she exercises that agency in her professional practice, and how sometimes simply asking the right questions can enable us to see how universal access benefits everyone.
I this perfectly segues into the other thing that I wanted to talk to you about, Diana. You're telling us about ways in which you disrupt ableism on an everyday basis in small ways and big ways. Let's acknowledge that just by being in the space and by being open and talking about your disability, writing about your disability, that you are disrupting the environment, right? In a good way. You do this in many ways across many avenues. So you're not just advocating at prime opportunities when someone says something or someone does something, these little acts of disruption or these little acts of being an accomplice for others. You're doing this in major ways in major organizations, including your own association. Can you talk more about how you're doing this?
So I've had a little discussion with a resident not too long ago who was interested in getting more involved in advocacy at some level. And she asked me, how or why I started. And I'm like, I got angry. That's what happened. I'm not even angry about my own situation. I think it took a lot of processing for me to kind of get to the point where I understood what had happened in my own case and could really think about it objectively, but also let myself feel the emotions that I was feeling about it. I started getting angry when I started to see the same thing happen to my patients. And I kept hearing stories and I kept hearing the same thing, if not the same, condition, then hearing the same kinds of outcomes, the same kinds of interactions, the same kind of problems in the same kinds of patients. And I just decided to start being a little bit more loud about things. I'm a pretty quiet person by nature, but I like to think that I'm in a weird spot where, on the one hand, I have this history of my doctors not listening to me, but at the same time, I'm a doctor, so now doctors will listen to me professionally, if not personally. So, by the virtue of having these letters behind my name, people see that and kind of take what I say a little bit more seriously. I have also noticed that when I tell my own story and I tell my story to fellow physicians, it might be the very similar things that they've heard from patients. But I say it because I have, MD, MPH, all the rest of them behind my name. And all of a sudden it's like, oh, we should take that a little bit more seriously. Oh, we should listen to these things. Even in my own advocacy, I feel like I'm not saying anything that disabled people have not been saying for generations. And I'd like to be very clear about like who I'm drawing from, who you need to be listening to, who you need to be talking to, not me, because I feel like I'm just trying to be a microphone in this case, more so than like talking about other things. So usually when I think about disruption, as it were, which I love that term, I just think about it as being the one who's willing to just comment. And it doesn't always have to be that I'm like screaming into the night. Sometimes it's just, why can't we just do this way? Have you thought about this? So I'm pretty involved with our professional societies. And I remember I was invited to be in like a leadership program, which was a great program. But at the same time, we were having all these conversations about like diversity, inclusion, equity, all that kind of stuff. And I remember thinking, at the same time, I'm representing, pediatric neurology, but I'm also being like, hey, hold on a second. We're talking about diversity, inclusion, equity, disability. We haven't talked about that at all. We're going to say something about that. We're going to talk about intersectional kinds of things. And I remember asking someone who was kind of higher up about that question directly and getting some questions back like, oh, we hadn't thought about that. And then that turned into, other opportunities to do talks or educational sessions, or to be involved in planning for some of these activities for our organizations. So I think a lot of the times it's not even me just getting, even though my first little spark was because I got so angry about what was going on. It's that now I feel comfortable enough to say, can we just take a pause for a second and think about disability in this aspect? So even, I'm on this other planning committee, and we were talking about different things that we wanted to do to make sure that there were standards for presentations. And I said, are we going to be talking about the disability aspect? Are we going to be talking about accessibility? Are we going to have captions? Are we going to have this? Are we going to have that? What about like alt text what about visual descriptions? And sometimes at first, when I'd start to say these things, people would say, well, we can, disabled people, they have an opportunity to say that they need these accommodations. And I can just say things like, why not make it universal? So that people don't have to disclose their disability if they don't feel comfortable. Or because if we're doing universal design, then we might help people that we don't necessarily think are going to need those accommodations who turn out to need them. In my own little world, I specifically remember when I started kind of doing more visual descriptions of my presentations, and a colleague came up to me, and this person, English is their second language, and they were like, at first I didn't know what you were doing, but then I realized that once you described it, that was the first time I could understand what that particular graphic meant. And again, this isn't a person with a disability. This is a person who just needed accommodations and didn't even recognize that they needed them. So I think it's as simple as asking a question. I know a lot of times when I talk to residents about this kind of thing, they always think about the power dynamics, the hierarchy, and how in the world you can say things. But one, I don't think that residents and trainees recognize the power that they have collectively. That's a whole other side thing. But sometimes it's just as simple as saying something small, something little. I know another thing that we have done that I've been trying to do is try to reckon with ableist language that we use when we're talking about patients, when we're writing it into our notes and our reports. And I specifically remember, having a little side conversation with a resident as we were doing some of our didactic education, and then months later hearing them say like a different term and being like, look, see, I didn't have to yell, didn't have to make a big fuss. I just had to say, have you thought about doing it this way? And I like to think that that's kind of what I'm trying to do. I always say that I'm kind of annoying different organizations that I'm involved with because I'm always going to bring up disability. But at this point, I think that they've come to expect that from me. And what I'm hoping is that that starts to plant seeds so that when I'm not in the room, other disabled people are not in the room, they still have that kernel of knowledge and can start to apply it to the next situation.
I love that, because what you're essentially saying is everyone has power to disrupt ableism, and everybody has power to do it in a manner and in a level of impact that is comfortable for them. You can certainly be an ally, but you can have these conversations in little pieces, right? Or you can have them in larger pieces as you become and grow in your understanding of ableism, as you become more comfortable with acting and disrupting and explaining kind of anti-ableist principles. So what that does is it takes something that might be scary for people, especially people that don't have disabilities, and it invites them to be that ally in that space by saying it is the little things oftentimes. It's like you can have a death by a million cuts, but you can also have healing through a million small acts. The other thing that I love that you talked about was how you are using your power and privilege in these seemingly small ways, but that are educational. I agree with you that let's not wait for people to tell us stuff, because there's so much power and privilege, especially in medical spaces, medical training spaces, that if we do that, we will have people who don't come forward, and we will have people that don't even know that these things assist them. Uh, so many people use captioning now, and it helps them process it. There's so many benefits to it, even if you don't have a disability. But you can also bring this kind of disruption, this activation, this serving as both a person with a disability that's disrupting the environment and as an accomplice across all groups that are marginalized and oppressed, by also saying things like, I won't sit on a panel that is all men, right? I mean, we wouldn't be asked to do that either, but for the men listening in our audience to say, I won't sit on a mantle. There are enough women in medicine now. You can find a woman in medicine to be informing that panel alongside you. Similarly, I will not be part of a panel where representation does not reflect the diversity that we want. There's got to be representation at those intersections where people, as you described, have experienced multiple marginalization, and because of that, they've had different experiences. So if we're going to talk about experiences, we're not capturing all of the experiences if we're not inviting other people to that space. Now, a caveat that we were talking about earlier to this is those individuals that sit at the intersection of a minoritized race or ethnicity, a marginalized sexual identity, those are the people that have been harmed the most in most circumstances. Those are the people that are the most fearful of outing themselves as disabled. And those are the people who are asked to re-traumatize themselves by telling their stories on panels, oftentimes for free, oftentimes for the benefit of a majority group that is, again, checking a DEI box. So we have difficulty. We try our best, but we have a lot of difficulty. And I am being obviously both an ally and an accomplice in those spaces by respecting people's decisions to say no. But I'm still struggling with how do we reconcile that, and how do we acknowledge that so that we're acknowledging those voices that aren't being heard in that space and amplifying why they're not being heard.
One of the first things that kind of comes to mind is, and I don't know how to say this so that it doesn't sound flippant, but ask, especially if I'm thinking about Black disabled people, ask Black disabled people to come talk about their expertise in other areas. So it could be like, oh, yes, absolutely. You want to make sure that this viewpoint is included, like in your DEI presentations, in your talks about racism, in your talks about X, Y, and Z, but also like I like to think that I have some expertise in neurodevelopmental disabilities right now. So if you wanted to talk about that, like you can, like that's totally fine. We can talk about those things. Although I will say, though I am somewhere under the neurodiversity umbrella, I'm not autistic. So even if I'm coming into a space where I'm talking about issues that are affecting my autistic patients, I like to make sure that that voice is represented and use a little bit of my privilege to say, hey, can we have an autistic person as part of this panel? Are there going to be autistic people that are working on this thing, X, Y, and Z? And that's, again, just an example of how you can kind of leverage your privilege in those cases. Because, I mean, you're right. There have been so many times, especially after everything, that happened in 2020, it was like every other person was asking, like, oh, let's ask a Black person about their pain and their trauma. And yes, we need to talk about those things. Yes, those voices should be centered in those conversations. Yes, but also, I'm a doctor. I have other expertise. You want to talk about those things, invite me to those conversations as well. You have other people with other identities who, of course, they have expertise. They can talk about their lived experience. They can talk about their trauma. But, everybody has their own specialty. Maybe there are other things that they're working on. Maybe their research focuses on other issues. Maybe there's something else that they are an expert in. Start inviting them to those things, those panels. And then I think when it comes to time to talk about those other traumatizing or difficult conversations to have, it feels more like you're treating us as a person rather than just as a story and as kind of as entertainment.
And that's powerful. And I do feel First of all, I 100% agree. They're not just a person with a disability. They're not just a person that's Black, brown, or part of another population that has been marginalized. It is their academic scholarship to look at as well. You know, switching gears a little bit, I feel like we have something in common that we've actually never had a talk. For all the talks that we've had, we've never talked about this. But in the last 3 to 4 years, I've had a lot of loss. We've all had a lot of pain in so many areas. And I've taken to writing to help me process this. And I know that you are a prolific writer in kind of storytelling and doing all sorts of genres, and you're involved in writing camps, and you've done some more popular writing and things like Alice Wong's first book, and I think there was another book that recently came out that you were part of. Can you talk to us about how that's been meaningful for you, and in what ways it's allowed you to heal and process some of these things that have happened?
Yeah, writing is, I don't know. I don't know that I have enough words to explain what writing is to me, but it is something that has been important to me personally since I was a child. I remember writing really terrible stories even when I was little, and poems and songs and all kinds of things. But when it came time to go to medical school or to start applying to med school, I took some really bad advice because at that time I was trying to make myself look like a little star applicant. Organic chemistry was kicking my butt, so I wasn't doing that great in organic chemistry. But at the same time, I really got involved with creative writing. At that time, I was doing more short fiction and plays and things of that nature, but really getting involved in like the campus literary scene, edited the little campus literary magazine, and was like working with this nonprofit. So writing was just amazing to me. But at the same time, someone was like, well, you can't be a doctor and write too. So you got to cut something out. And so I did what I was told, because they were like, well, those conversations, it was kind of like, well, you're going to have to score at a certain level because, you've got a lot of things against you. And we could certainly talk about the whole racism in pre-medical processes later, I suppose. But I thought that I had to do a certain thing, live up to a certain standard, be a certain way in order to become a doctor. So they said, you can't write. So I didn't write, and didn't write for close to a decade. Even after I had my illness, I remember one of the first things that my family started to tell me was that I needed to write about it because they knew that that was something that was important to me and that it was a story that should be told. And not that I didn't believe them, I think that it was more that I did not have the time to process and think about everything and didn't know what to say. And really did not write a single word about everything that had happened to me, or really write much of anything apart from I carried around a little notebook that sometimes I would write like title ideas on, and that's it. That's the extent of the writing that I did for years. But the maybe 2 or 3 days before the third anniversary of my stroke, I woke up feeling like I just had to say something, and I couldn't think of what it was that I wanted to say. I remember I walked to work and I just kept thinking that I wanted to get something out, and I couldn't think of what it was because my anniversary was approaching. And I remember talking about how I was excited about the anniversary of my stroke, and people being like, that's a weird thing to want to celebrate. Although, no, I mean, I was alive. that was a thing that I think is worthy of celebration. I kind of wanted to write something about that. So I couldn't think of what it was. Went to work, went around, was sitting in the epilepsy monitoring unit with an attending. A couple hours later, he was pointing out all these things on the EEGs that I was supposed to be listening to. I was supposed to be taking notes, but what I was actually doing was writing a little essay on my phone, and ended up posting a piece of it on Facebook. A lot of people responded to it. They said, oh, you should do something with this. You should make it bigger. I said, no, it's nothing. And then one of my co-residents lovingly badgered me for weeks to do a little bit more with it. and told me that I should submit it. And I said, no, nobody's going to want to see this. That's not a thing that's going to happen. But really, honestly, just to kind of get her to shut up, a couple weeks later, I said, okay, I'm going to submit it. And I did. And it ended up getting published. And that was my first publication. I, of course, was like, that's completely a fluke. I'm not doing anything with this. But then maybe 6 months or a year later, I remember having another conversation, which someone was like, oh, you must be an everything happens for a reason person. I can't deal with those. And I was like, huh, I need to do something with that thought. And ended up writing another little essay, said, well, maybe the first one was a fluke. I'll send this one out and see what happens. And that ended up getting published. And then after that, I started to recognize how it made me feel to get the words out. I still think that there are things that I write that I cannot say. And even though I can technically, like if I'm reading that particular essay or what have you, I can read it and I know that that is my authentic voice. But it is still hard for me to kind of talk about with how I was feeling with some of the things that happened. I know in medicine, we really do not like to talk about mental health. We do not like to talk about the effects of critical illness on you mentally. But I really struggled with that for a long time with, my anxiety, with post-traumatic kinds of stress issues, all related to my ICU stays and everything else that kind of happened with that. And so in writing, I felt like I had a space where it was okay for me to say things that I didn't feel comfortable or safe enough to speak aloud. Thankfully, it got to a point where I was really struggling finally came to a point, this is years after the fact, where I was ready to kind of process everything that happened, really struggling with some strong emotions, knew that I wanted to do more writing, and I just so happened to run into this young adult cancer survivor writing group. Signed up before I could talk myself out of it, and really started working with that group. The organization itself is called Cactus Cancer Society. It used to be called Lacuna Loft, and I cannot say enough things about that writing group. Now they have different writing programs, but I remember when I first started going to the group, I at first didn't write anything, didn't want to talk, but just it was so nice to be in a space where there were other people who we had different stories, but I could come there how I wanted to. If I was having a day where I was having a lot of pain, they didn't care. If I didn't feel like writing, they didn't care. If I wanted to write something really angry, which most of what I wrote at first was very, very angry, they didn't care. And other people understood and could talk about how the writing made them feel. So I continued to kind of go to writing group, continue to start to get more comfortable about talking these things. Went to therapy because that was definitely needed, and started to use writing not only as a way to kind of process how I was feeling, but also express how all of this in a way that's not just, let me tell you a very cut and dry story about my healthcare, but try to do it in a way that is lyrical, that is poetic, shows how beautiful the body can be, even when it kind of falls apart. So now, I don't know, I write, I guess. If I keep saying it, then it'll make it true. I'm working on a book right now that kind of talks about all of these things. I just had a little essay, tiny, tiny little essay that was published. And I don't know. I just feel like on the one hand, part of me is like, well, I keep writing about the same thing all the time. And I think that part of the reason for that is because there is still so much that I feel like needs to be said, but not just about me, because I also like to do writing about medicine and the healthcare system kind of broadly. And I feel like part of the reason for that is because, yes, it helps me process, but I think that writing can also be a way to communicate and educate in a way that, like, our academic articles, amazing. I need to get more of them. But at the same time, ain't nobody reading what I have in like the Journal of Pediatrics, except for pediatricians. But if I write an essay, it might be something that's more accessible to someone who's outside of medicine, who can read it and see it and say, hey, I see you. I've felt this. I understand. So it also has been a way for me to connect with other disabled people, other writers, and there are lots of disabled writers, and just be in community with each other.
Have you ever considered taking a course or getting involved in a narrative medicine program?
Yes, I keep thinking about it, and keep thinking about it. And at some point, I probably am going to want to get more involved. I feel like I just kind of tiptoe at the line of narrative medicine quite a bit. And one of my colleagues actually is pretty involved with one of the health humanities programs that we have here at our institution and has been threatening to pull me into the water for a couple of years now. But I don't know. I feel like it's going to happen. It's just kind of when and where. And maybe I need to push around some of the other things on my plate so that I can make space for it.
I don't know if you have the same experience. There's a book in me, and it will come out at the right time, right? It will come out. But with my writing, I have an idea and it kind of floats there for a little while, and I'll come back to it and go back and forth, and I'll have these little moments where something will pop in my mind and I'll put it on my voice memos or in my notes on my phone. And then I'll wake up one morning and it will just all come out. I can't even describe it. The essay I wrote for JAMA, Peace of My Mind, about my mother passing away was, I think, about a month after she passed away, and I was getting on a plane to go for the holidays. I remember sitting on the plane. It was a 3-hour flight, and by the time I landed, the essay was done. And like what you've described, I was like, okay, if I don't send it in right now, I will never send. So I sent it in just, no editing, just in raw form. And I thought, if I don't do it now, I'll never do it, because I'll sit and just ruminate over every sentence and then it will be too polished and the kind of visceral part won't come through. So I wait for those moments and I know they'll come, but I can't push it. You know what I mean? It's almost like your brain is processing on a certain timeline. But you said something, I think, that is so profound, and I'm sure many of the people listening to this will pause in the moment. I actually put a little clip in our note for myself. You said, and I think this is verbatim, I write about things I still can't talk about. And that's powerful. And I would encourage anyone who is struggling with things, they tell you this in therapy, write a letter to the person. You don't have to give it to them. You can burn it. You can throw it away. But writing really helps your brain in some way, shape, or form kind of come to terms with some of these things. And just as I was hearing you tell your story, it's not the first time I've heard parts of it, but it is the first time I've heard other parts of it. And even I am just taken aback by how anyone survives that and doesn't leave medicine. And I think this is so central to one of our big arguments about academic medicine, especially calling for resilient medical school applicants, resilient people. And then in the same call, really questioning disabled people. And I want to say this is one and the same. These disabled people have been through more collectively than most medical students will have ever been through. They are more connected to patients prior to even entering medical school. They know what it's like to be there. And that's an important quality that I think we will uncover leads to more empathy and leads to better patient care. We end every session with, what advice would you have for the listener? And it doesn't have to be concordant advice to someone going into neurology or to someone who, is a stroke or cancer survivor. It can be to anyone. It can be to the schools, to the student.
I mean, I think the biggest thing, and just thinking about like resilience, which I have a hard time with that whole concept. I feel like I'm not resilient, I'm stubborn. And I since I was a little child, I wanted to be a doctor and constantly heard, like, no, that's not going to happen. I grew up on a farm. My mama had me young and had very limited access to medicine for various reasons. At the same time, so I was not who's supposed to be a doctor. Even when I first started saying this is what I wanted to do, I was like, yeah, okay, I'm just going to keep going. And even family members at some point were like, oh, that's nice, baby. And I'm like, yep, okay, I'm just going to keep going. And then when I got into, college, and even when I was struggling with chemistry, they're like, you're never going to be a doctor. I specifically remember one of my professors, one of my organic chemistry professors, who told me I would never be a doctor here or in Cuba. My father's side of the family is Cuban. She said that to me in Spanish. I said, okay, I'm just going to kind of take that. And I I don't know. I feel like this is the only thing I've wanted to be. This is the only thing I can see myself doing and being decent at. And this is where I feel like I'm supposed to be. So, yeah, I mean, I've had a lot of things that have happened. I have a lot of complicated feelings about those things that have happened, but at the same time, I feel like if this is for me, this is for me. If something is for you, it's for you. And I know that that's something that's kind of cliche to say at this point, but I do believe that there are people who just know that they're supposed to be in medicine, that they're supposed to be physicians, and that's it. And once you get here, I feel like I like to think that the work that I'm doing is making some kind of difference, trying to make medicine a little bit better, because I believe that what we could do and what happens every day, like there are little miracles that happen in medicine every day, and we could do so much to transform this system so that it works for more people, it works for everybody, it works for the most marginalized among us, the most vulnerable among us. I truly believe that. And even though I have been hurt and harmed by this system, I think that by being here, I can help try to change it. I know it's going to be difficult. I know that there are going to be times when I have to do a lot of balancing. That's something I've certainly been having to figure out the last couple of months, because it's hard. Burnout is real. And I feel like, particularly as a Black disabled woman, there are lots of different things that are coming for me and coming for my energy and my time and all that kinds of stuff. So I certainly have had to learn how to draw boundaries. But all of that to say, I believe that there are other people out there that are thinking about coming into this field, worried about what's going to happen. I was, still am sometimes. But I think if you believe that you belong here, you do come on over. Know that people are going to tell you no. Keep going anyway. And then at the end of things, you can just be like, hey, hi, yes, that's MD behind my name right there that you said that I wouldn't be able to do. It's always fun to kind of be able to look back. But I will say, part of the reason that I'm here is because I've been able to find my place and my people in particular. I'm lucky in that there have been people who have been willing to fight for me, if not with me. And the further along I go, the more accomplices I have, and not just in medicine. Although it's been wonderful to find like I truly believe that the people that I'm working with, like in my research, at my job, on some other projects, even in the whole docs with disabilities community, I truly believe like, oh, here's my group. This is who I have who can help sustain me as we go through this kind of time. And it's not always going to be great. There are always going to be kind of hills and valleys during medicine, even when you're in practicing. But I honestly believe like there are people that are there who believe in what I do, who are willing to fight for me, who are willing to fight with me, and who we can kind of help sustain each other. And that includes my family, my friends, who have been there for me when there have been times where, I have not seen it for myself. I have thought about, should I make a change? Should I quit? Is there something else that I should do? And who have recognized that like that's not what I truly want. So let's figure out how we can support you so that you can get back to the place where you feel like you can stand up a little bit more on your own. So I would say, yeah, be stubborn. Also find somebody who is, I'm thinking about one of my mentors who I describe her as someone who I feel like legitimately would fight somebody in a parking lot for me. And so try to find that person. several of those people, because I think that, we all need those things, particularly trainees who are coming up.
I love that. Community is so important. And I do love our Docs with Disabilities team and our Docs with Disabilities community. I also have people that you put out the call and they're like, I have a shovel. Where are we going? Like, where, it's because we all experience that hate in one way or another for multiple reasons. And we need those people that are in our corner, ride or die. And yeah, that makes the work easier when you are part of a community and you're all leaning on each other.
Yeah, that's for sure.
Thank you to our guest, Dr. Diana Cejas, for gracing our audience with this important and necessary conversation. To our audience, thank you for joining us. And if you've enjoyed this discussion, be sure to subscribe to our podcast and check out our previous interviews. This podcast is a production of the Docs with Disabilities Initiative and is supported in part by the University of Michigan Medical School Department of Family Medicine Disability Initiative, the Stanford Medicine Alliance for Disability Inclusion and Equity, the Ford Foundation, and the Robert Wood Johnson Foundation. The opinions on this podcast do not necessarily reflect those of the hosts, their respective institutions, or the funders. This podcast is released under Creative Commons Attribution, Non-Commercial, Non-Derivative License. This episode was produced by Kadisha Trigo, Jacob Feeman, and Dr. Lisa Meeks.